In this short PowerPoint presentation, I'm going to explain to you how we need to think about preeclampsia in a different way, and particularly how preeclampsia can exist in two quite different isoforms and what that really means. So we've known for a number of years that cardiovascular function is recognized as a key component in the pathophysiology of preeclampsia. I love this particular analogy from Herbert Valensis, one of the co-authors of this current review paper. Herbert tells a story of the cardiovascular system and the placenta as really a radiator and boiler system in a house. It's a central heating system, and you need the boiler to provide hot water to go through, pass into the radiators, and heat up the house. We've been focused about the uterus and placenta as the radiator, as the cause of uteroplacental insufficiency and the cause of preeclampsia. But why don't we think for a moment of the boiler? And in the boiler, you've got two components. You've got the pump, and you've got the blood vessels or the pipes. If the blood vessels or pipes are too obstructed and too thin, hot water doesn't get through them. If the pipes are absolutely perfect, but the pump isn't pumping, hot water doesn't get through to the radiator. So let's think for a moment about preeclampsia as a problem of the boiler and not as a problem of the radiator. So let's talk about the two phenotypes of preeclampsia that have been reported in the literature, and they've been separated by early preeclampsia and late-onset preeclampsia. Usually an arbitrary definition is given of less than 32 and greater than 32 weeks, but this definition actually works reasonably well. Going back to the paper from Rome from Herbert Valensis' group in 2008 in hypertension, Herbert found that in early preeclampsia, which was commonly associated with fetal growth restriction, there was high vascular resistance and low cardiac output. And you see this in this left-hand circle here, where cardiac output is along the x-axis, blood pressure along the y-axis, and there are lines to denote vascular resistance. And we see that low cardiac output, high vascular resistance, high blood pressure is particularly associated with early onset preeclampsia. By contrast, if you look to the right, you see another yellow circle, and this denotes late preeclampsia. And the odd thing about late preeclampsia is the cardiac output in these women is much higher than that of the early preeclampsia. Part of this might be explained by gestation. But the other interesting thing is that the vascular resistance is much lower. So it's probably about a half of that of the early preeclampsia. So what's that telling us? I think it says that there are two different cardiovascular phenotypes, one characterized by high cardiac output and low resistance, which is the late preeclampsia, and one associated with low cardiac output and high vascular resistance, which is the early preeclampsia. Now, there's a complication here, and that is that early preeclampsia is commonly associated with fetal growth restriction. Probably 80% of cases are. Late preeclampsia is much less commonly associated with fetal growth restriction. But the truth is, you can have fetal growth restriction in late preeclampsia, and you can have not fetal growth restriction in early preeclampsia. So it may not be that the definition is based on early and late, but it may be that it's a cardiovascular phenotype. So let's see if that's true. Jasmine Tay wrote this very nice paper, which was the subject of her PhD over the last 4 years. And in it, she recruited women with fetal growth restriction, with preeclampsia and fetal growth restriction, and normal healthy women from any time after 24 weeks until term. So we didn't differentiate by gestational age at onset. We also managed to normalize all the Doppler measurements and all the cardiac measurements for gestational age. So this study was done blind to gestational age. We forgot for a moment about early and late preeclampsia. Well, what did we see? Well, cardiac output is the panel here on the left. And you can see that preeclampsia only is associated with high cardiac output compared to controls. Preeclampsia and fetal growth restriction is associated with low cardiac output and lower than that of controls. If we look at preeclampsia and preeclampsia with fetal growth restriction in respect of peripheral vascular resistance, we find exactly the opposite. So if there's preeclampsia alone without growth restriction, the vascular resistance is lower than controls. If it's preeclampsia with fetal growth restriction, it's higher than controls. And that fits with the cardiac output. As cardiac output is increased, often vascular resistance decreases, assuming blood pressure remains constant. Now, the importance of this was that we were blind to gestational age. So preeclampsia at any gestational age, if there wasn't fetal growth restriction, showed a specific cardiovascular phenotype. And that cardiovascular phenotype was high cardiac output, low vascular resistance. Preeclampsia with growth restriction, by contrast, at any gestational age, the cardiac output was lower and the vascular resistance was higher. So we were able to say with a high degree of certainty from this work that early and late tells you something, but actually isn't the cause for the two different phenotypes of preeclampsia. It's an association, but not a cause. Gestational age is not the cause. Well, cardiovascular function and preeclampsia and fetal growth restriction are not new concepts as related to one another. Over the last 10 to 15 years, many authors from the UK, from Europe, from the US have looked at this. And they've also looked at cardiovascular function from early on in pregnancy. And there are interesting signals or clues that early on in pregnancy, women who go on to develop preeclampsia or fetal growth restriction are different and have different cardiovascular function than those that don't. But I suppose the question is, if profound cardiovascular changes occur in very early pregnancy, is it just early pregnancy, or might they occur prior to pregnancy? In other words, might it be that cardiovascular dysfunction prior to pregnancy sets a woman up for developing preeclampsia and growth restriction? To answer that question, Lin Fu, another fellow here at Imperial who obtained a PhD just last year on this work, recruited a very large number of women. In conjunction with a study from Cambridge, 530 women who were assessed prior to getting pregnant, and these women were all trying to conceive. So we followed them throughout their pregnancies and determined which developed preeclampsia and growth restriction. And of course, only a small number actually did develop preeclampsia and growth restriction, but within that small number, you can see that prior to pregnancy, these women had a lower cardiac output and a significantly higher vascular resistance than control healthy women who did not develop preeclampsia and growth restriction. In fact, prior to pregnancy, healthy women who developed preeclampsia had a 16% lower cardiac output and a higher vascular resistance than those that had healthy outcomes. And I should say that these women all had normal blood pressure, so it is wrong to assume if you check their blood pressure, they'd have higher blood pressures. Although some of them might, in general, they had completely normal blood pressures, so you would not know the cardiovascular system was affected unless you had actually done specific cardiac output and vascular system measurements. So, in summary, we've heard that preeclampsia exists in two phenotypes, and these two phenotypes are opposite from the point of view of cardiac output and vascular resistance, and actually intravascular volume. And the key discriminator of these different types of preeclampsia aren't whether they're early or late, but whether there's growth restriction present or not. Growth restriction leads to the low cardiac output, high vascular resistance form of the condition. Comprehensive assessment of the hemodynamics of these women, combined with ultrasound and Doppler investigation, can guide rational choice of antihypertensive and fluid management in preeclampsia. Don't forget that some of the antihypertensive treatments we use have different modes of action. They may be vasodilators, or they may reduce the cardiac contractility and cardiac output. This is very important if you're considering that one form of preeclampsia is because of vasoconstriction, and the other form is because of a high cardiac output. And finally, pre-pregnancy cardiovascular function may condition the risk of preeclampsia and fetal growth restriction in women, in which case, potentially, there is a way to intervene before they get pregnant. I will leave you with that thought, and thank you for listening.